Sounds good. Thank you for this opportunity to speak today. So for those of you who don't know me, I'm Jeanne Gallet, and I'm a PhD candidate at Harvard University in the program of Speech and Hearing Bioscience and Technology. And as you can see, my talk today is entitled Quantitative Assessment of Meaningful Speech Production in Primary Progressive Aphasia. So I'd like to begin my talk with my acknowledgements right up front. So first and foremost, I'd like to thank the patients, caregivers, and families of the Frontotemporal Disorders Unit at Massachusetts General Hospital for their invaluable contributions to this work and all the time they've taken. And furthermore, I'd like to thank the members of the speech and language team at the FTD unit for all of their clinical care and evaluation. I'd also like to thank Brad, Associate Neurologist at Harvard Medical School and MGH, and Evelina Fedorenko, Associate Professor of Brain and Cognitive Sciences at MIT, for mentoring me throughout my PhD. I'd also like to say that this work was sponsored by the National Institute of Deafness and Other Communication Disorders, as well as the Dingwall Foundation. So, this talk is occurring through Focus Aphasia, which for those of you who don't know, is a wonderful international initiative that brings together researchers and clinicians for the topic of how to foster the quality of spoken discourse in aphasia. So as a plug, if you haven't seen the website or are interested in membership, I've listed the link below for you to check it out, though I assume all of you who are here live are already members. And so it therefore follows that my primary interests are the study of discourse. And I'd like to start this talk with a metaphor. So if we consider discourse as a diamond, we would say that discourse is made up of countless facets and their interplay. These facets range from the verbal to the nonverbal, language-based to articulatory mechanisms. And while discourse brilliance comes from these facets and their interplay, we don't currently have an objective way to assess what makes one person's discourse more brilliant than another's. So my approach in this study is to zoom in on one of these facets and to study it quantitatively. And that facet is lexical production, namely as derived from connected speech in primary progressive aphasia. As a brief overview, primary progressive aphasia, or PPA, is a devastating neurodegenerative aphasic syndrome where aspects of speech and language are selectively impaired at the mild to moderate stages before heading into a global decline. Right now, we have 3 variants that we use to classify patients with PPA. The first being logopenic PPA, which was introduced as recently as 2008, the non-fluent variant, and the semantic variant. So here I've put together a table for you that's mirrored off of the work by Gorno-Tempini et al. From 2011, where in the first row I have listed the primary deficits for each of the 3 variants, and below the 2 or more symptoms that are required to make a founded diagnosis. So if we go through the 3 variants, we see that for logopenic PPA, the primary symptoms are word-finding difficulties or anomia, and impaired repetition. In the semantic variant, we also see anomia being a primary deficit, but this is accompanied uniquely by single word comprehension deficits. So these individuals are unable to retrieve words, but also have this degradation of semantic representations. And then finally, we have the non-fluent group, where we see simplified grammar or impaired syntax, accompanied by effortful and halting speech, sometimes led by motor deficits, and speech sound errors. Recent work has also shown that there is anomia present in this group. And so while we do have these distinct variants, at onset, the majority of individuals with PPA do suffer from a deterioration of lexical retrieval. This, in turn, motivates my own research, where I aim to examine the mechanisms by which anomia manifests in these 3 variants of PPA, and in turn, how this impacts discourse. So I'll go right into my aims, but I'm going to go through a lengthy discussion of methods and applications of my work before going through my own results. So my first aim is to identify the relationship of lexical variability and task-specific meaningfulness I skipped a slide, to analyze the variability of lexical selection, proportion of word class, and proportion of meaningful output in connected speech in PPA and healthy controls. And then the second aim is to identify the relationship of lexical variability and task-specific meaningfulness in connected speech. So one very popular device to elicit speech from individuals with aphasia, both chronic and progressive, is to use a picture description task. So what the example I have placed here is the picnic scene from the Western Aphasia Battery. And this is a tool that's commonly found in clinics, including our own, where our individuals are shown this picture. We turn on a recorder and we ask them to describe what they see or to even tell us a story about it, and ask them to use complete sentences. And so while this task isn't quite representative of a natural conversation or natural discourse, it does allow us to have a constrained prompt that allows us to compare participant responses. So here's an example of what someone with logopenic PPA might produce. On first glance, there's a lot of output. We see that they're using words to describe the picture, and we also see a lot of filler words. But these are all mostly qualitative observations. So one quantitative measure that we can use to really objectively examine this output is to look at proportions. So namely, proportions of word class. Proportions allow us to compare the relative magnitude of two distinct measures, such as the ratio of nouns to verbs or the ratio of nouns to all output. Importantly, these proportions allow for a comparison between categories. So applying these to this specific sample, we can derive the proportion or percentage of output that is dedicated to a specific word class. So while nouns and verbs occur at about 17 to 19% of the output, we also see that filler words and false start dominate 12%. Another objective measure that we can apply is the type token ratio, which was initially proposed by Templin in 1957. It's a very simple calculation. It's the division of the unique instances of a word or an utterance divided by the total number of instances that this word or utterance occurs. They allow us to examine how much unique information a person communicates overall and by word class. It's been popularly used in the developmental literature, but in my opinion, Heather Harris-Wright really pioneered the use of TTR in chronic aphasia. Importantly, I also believe that type token ratios provide insight into the ways in which lexical access declines. And what I mean by that is that the TTR ratio is scored from 0 to 1, where if you are at the one extreme of having a 1, the correspondence of unique utterances to total utterances is 1 to 1, meaning that a person is probably communicating atypically if they're saying more than a few sentences. So you would at least expect the conjunctions or prepositions or filler words to be repeated. On the other end, if you have a TTR below a specific level, a person is likely using the same words or phrases to communicate different things. And so what this TTR score tells us is a little bit about, especially in cases of aphasia, is the ways in which lexical access declines. Do they become more general in their speech, or do they become more specific? And so applying TTRs to the same speech sample, we can see that this person indeed does have reduced lexical variability in their output, where the total number of unique instances divided by the overall total results in 0.39, which, as in the slide before, is below the normal cutoff. We can also apply this to the different word classes that we have in the English language. And what you can see here is that's the same calculation, the unique instances divided by the total number of instances, which results in TTRs. Importantly, while this does allow us to compare between word classes in an individual, we don't have normative data of what is considered usual for the specific word classes. So what we would need to do to contextualize these results is to compare these results to those within a diagnosis, across diagnoses, and to healthy controls. And so there is an ongoing debate about the utility of looking at these different types of behaviors within subtypes due to the ongoing research showing that there are a lot of differences within these diagnoses. However, based on our clinical experience at the FTD unit, there is this thought that there are dissociable differences in lexical variability by subtype. Another motivation for looking at lexical variability and proportions of word class is that the specific word classes that have been shown to be impacted within the variants of PPA, such as by the comprehensive review by Stephen Wilson in 2010, is that they can greatly affect the degree to which meaningfulness is impacted in a person. So if we were to give an extreme example, if there's one person where articles are reduced and they're unable to produce the word the, and another person where nouns are reduced, the first person would probably be able to communicate extremely meaningfully relative to the person where nouns are reduced and they're unable to describe objects and agents around them. So this brings me to my own study. I collected data from 115 participants, 32 of which had logopenic PPA, 28 had non-fluent, 24 had semantic, and 31 healthy age-matched controls. And so I looked at all of these patients on the continuum of disease progression using the clinical dementia rating scale, where I looked at the language score in particular, where a 0.5 is indicative of a questionable disorder, a 1 is indicative of a mild deficit, a 2 moderate, and 3 severe. So exclusionary criteria was a CDR score above 2. Overall, I collected speech samples using the Western Aphasia Battery Picnic Scheme. Every recorded sample was transcribed by 2 blinded scribes and then hand-checked. And then every transcription was processed to identify proportions of word class, type token ratios, and task-specific speech, which I'll get into in a bit. So we identified this list of word classes for every transcript. And from there, we calculated the following proportions and type token ratios. Next comes task specificity. So using the work proposed by R.G. Hillis's group at Johns Hopkins and their most recent article by Berube et al. In 2019, we looked at task-specific meaningfulness in our patients with PPA based on healthy control data. So we analyzed all the healthy control data, and if at least 2 healthy controls used a specific noun, verb, or pronoun that accurately described the picture, it was included in our corpus of appropriate words to use to describe the picture. And so we rated all of the PPA output relative to this corpus. Importantly, of course, there were phonemic errors at times. Sometimes someone used a plural or not, or a very, very close synonym. And so those were hand-checked by each of our scribes. And so a participant's task-specific meaningfulness score is based on the ratio of appropriate nouns, verbs, and pronouns relative to all nouns, verbs, and pronouns that they produced. And here I'm juxtaposing meaningfulness as 2 levels. The first being any type of meaningful communication that someone is able to produce. How much of what they say are we able to understand? The second level is how meaningful the output is relative to the context in which it is produced. And here, in this study, the context is the picture description. And so this created the following corpus, where you see that there are more nouns than verbs, but there are representative items for the nouns, pronouns, and verbs. The second aim was accomplished by correlating the proportion of word classes and the TTR measures with task specificity for every participant. And then the next step after that was to identify the best fit linear mixed effects model to examine the relationship of variability and task-specific meaningfulness. And for all my analyses, I used R. Quick plug for that. And that leads me to my results. So for the purpose of this presentation, I'm only focusing on nouns, verbs, and pronouns, but I do have the analyses if anyone is interested for all the other mentioned word classes. So to orient you towards to the graphs, on the x-axis, we have the groups listed, the healthy controls, logopenics, non-fluents, and semantics, split up by the clinical dementia rating language scores. So as expected, all the healthy controls are at 0, where there's no deficit, and then the 0.5, 1, and 2. And then on the y-axis, we have the proportion. So what we found for nouns is that the non-fluent group had a greater proportion of nouns to all output relative to healthy controls, logopenics, and semantics. For verbs, we saw that the semantics actually produced a greater proportion of verbs to all output than the logopenics and non-fluents. And what I'd like to point out here is that it's commonly assumed that for the non-fluent variant that this impairment to syntax is driven by a reduction in verbs. But what we actually saw here is that at the mild to moderate stages, we don't see that type of a difference. So the syntactic impairments that we see at the beginning stages at baseline assessment are not driven by a reduction in verbs. And then finally, we saw that the logopenic and semantic variants produce a greater proportion of pronouns to all output than healthy controls and non-fluent. Moving on to the type token ratio, we saw that relative to healthy controls, the logopenic variant had reduced noun variability. So orienting you to this graph, here the y-axis has the groups where the logopenic is the second from the bottom. And on the x-axis, we have the TTR calculation, which once again is the unique number of instances divided by the total number of instances, in this case, nouns. And so what we saw is that the logopenic variant produced less variability in nouns. So we're more likely to use the same nouns to describe something. For verb TTR, we saw that the non-fluent group had greater variability relative to both healthy controls and the two other subtypes. So even though they didn't produce a lower proportion of verbs to total output, they had greater variability in the verbs that they did produce. And then finally, for pronouns, we saw that the semantic group had reduced pronoun variability. So I think this result needs to be unpacked a little bit more because pronouns are a little esoteric when you compare them to verbs and pronouns. What this suggests is that when pronoun variability is higher, someone is making references to more individual agents. Whereas when it gets lower, they're making less references, which in the case of semantic PPA actually ended up meaning that individuals were making statements about themselves, I statements, which were tangential and unrelated to the picture itself. And so what that suggests is as pronoun TTR went down in individuals with semantic PPA, this might have impacted their meaningfulness and their ability to appropriately describe the picture and adhere to the task. And that brings me to meaningfulness. So here plotted on the y-axis, we have the task-specific noun, verbs, and pronouns based on the corpus from the healthy controls, divided by all nouns, verbs, and pronouns that were produced by each participant. And then on the x-axis, we have the groups. And once again, things are split up by CDR. And what we see is that the logopenic group and the semantic group perform consistently lower than the healthy controls. But the non-fluent group, at any of these time points, even though we do see a drop-off at CDR of 2, actually perform at the same level or even higher than the healthy controls. I think this is really important because this gets back to this point of what is effective functional communication, right? Because qualitatively, we can look at some of these transcripts and see, ooh, that is not a complete sentence, or someone isn't able to organize their thoughts super well, or it takes them a few starts to communicate something. But the non-fluent group, despite their difficulties with speech sound errors, with effortful speech and reduced grammar, they were the most successful at communicating within the context of this task. Aim 2. So first off, I'm showing you the correlations of TTR and meaningfulness overall. So I looked at this for healthy controls and the 3 variants of PPA. What we saw for the healthy controls is that there was a high correlation of pronouns and verbs to task specificity. So the greater the variability within pronouns and the greater variability within verbs, the better the task specificity score was for the individuals within the healthy control group. And this was also likely driven by the fact that normally you see more nouns than verbs in a statement. But with healthy controls, as I found out, a big difference in how they performed relative to the non-fluents, for example, was the amount of information that they produced. You often get healthy controls in the room and they're wondering what you're even trying to do by asking them to describe a picture. And it can take a little bit of convincing that this is about communicating what you're able to and to show your actual access to language. So here, what I interpret this to mean is that greater variability in verbs meant more sentences for the healthy control group. For the logopenic group, we saw a significant correlation of nouns and pronouns in terms of variability, meaning that the greater variability within pronouns and in nouns, the better the logopenic PPA participants were able to complete this task. For the non-fluent group, we only saw a significant correlation between the variability of nouns to task specificity. So the more variability of the nouns, the better they did. And then finally, for the semantic group, we saw a very strong correlation of variability of pronouns to task specificity, which builds off of the point I made previously, where we see that the more statements someone makes about things within the picture, referencing to agents in the picture that don't have anything to do with themselves, the more likely it was that the participants with semantic PPA were actually talking about the picture. And so further eyeball analysis of all of the transcripts, this turned out to be the case, that participants who performed poorly on this task were the ones talking about, oh, I've been to the ocean, and when I saw this, and this, they weren't talking about the picture anymore. So while they were able to demonstrate meaningfulness overall, it wasn't task specific. Then finally, looking at the linear mixed effects models results. So I went through a systematic step-by-step analysis to look at which factors of variability might influence or best predict and explain task-specific meaningfulness scores. And so for the logopenic group, the best fit model was noun TTR and pronoun TTR. Similarly, for the non-fluent and semantic groups, we saw the same significant effects that we saw with the correlations, where for the non-fluent group, noun TTR best explained task-specific meaningfulness, and for the semantic group, pronoun TTR best explained meaningfulness. And so while I wasn't able to go through all of the different types of results that we went through in terms of word class and TTR within them, what these analyses allowed me to do was create these unique profiles that suggest which direction different proportions and word class go in order to relate to the better task-specific meaningfulness score. And so one thing that everyone had in common is a lower pronoun to noun ratio led to better overall task specificity. And intuitively, this makes sense. The more someone is talking about objects in the picture versus making references to themselves or to others that aren't part of the picture, the more likely it is they're staying within the context of the task in their descriptions. Interestingly, we did see these differences where, for example, noun TTR was more important for the non-fluent group and the logopenic group, whereas for the semantic group, that didn't end up being a significant correlate or predictor of task specificity. And this points to the use of language. Someone might be able to meaningfully communicate statements that make sense, but they're not context-based. And I think that's a really important aspect to evaluate within this conversation about discourse, because if someone is able to say a lot that doesn't actually mean anything given the conversation, it isn't really successful in terms of communication. I also thought it was interesting that for the healthy controls, verb TTR and pronoun TTR were more important than looking at proportions of nouns or variability within nouns as well, suggesting that you need more statements about different things, about the actions that different objects have on others in order to communicate successfully in the context of this task. There were also differences in the use of adverbs and adjectives and their variability, also by subtype. And I'm more than happy to go over that if anyone has questions about that or would like to talk offline about it. But I think this also just really, while this is such a small aspect of discourse, this was my attempt to really examine one quantifiable way of lexical production. And I think that really is the cornerstone for a lot of what we do produce in everyday discourse. And so my next steps would include an analysis of spontaneous speech. So not looking at a picture description task, but maybe the next step would be to examine the question, what did you used to do for work? Or what do you do on a typical Sunday? Where you still have that constraint of a task overall, but you aren't asking someone to rely upon a picture that they're seeing. This does bring in other caveats where you're introducing different work experiences, different in terms of length, in terms of, for example, imageability of what they used to do, how specific the jargon is describing the work, but it also introduces this new aspect of naturalness, which this task does not. I'd also like to compare other types of early onset frontotemporal dementia that do not selectively impact language. So in addition to healthy controls, introducing other variants. In these analyses, I'd initially set out to include posterior cortical atrophy, but as it turns out, after listening to about 12 recordings, the majority of that time was spent commenting on the low visibility of this picture. So it didn't actually end up being feasible for this task, but I am working on a project right now where I am looking at spontaneous speech with posterior cortical atrophy. I'd also like a greater control sample size because as I had alluded to before, sometimes some of the healthy controls didn't have that same engagement with the task as we would have liked. So this aspect of motivation is super important when considering what we use as normative data. Even more so, when it comes to normative data, you have to look at the diversity of participants. In the Boston area, we do attract a lot of people for healthy control data who are within the university or from similar fields or married to someone within the university. So it does create a very specific sample set of data. And finally, I'd like to do a longitudinal analysis where we actually are able to monitor these changes. I attempted to show the breadth of change within each diagnosis by including the spectrum of CDR scores, but I think a single subject analysis would be more beneficial. So I sped through that talk, but I am more than excited to answer any questions and to start a discussion about what I've talked about.
Awesome, that was great. I'm happy to kick off one question, and then if people want to unmute and ask them, you're very welcome to, or if you're not in a place where you can unmute or don't want to, feel free to ask them in the chat, and Jen can monitor that. Could you go back to the slide where you had all the nice bar graphs organized by the dementia score? It'll just help me organize my thoughts. One more. Yeah, that one.
For the word classic?
Yep, perfect. So I was just thinking in terms of CDR, can you talk a little bit about how many people kind of fit within those 0.5, 1, and 2 groups? So did you have a lot more, I'm just thinking of individuals that I have seen or worked with, you know, was the non-fluent group or something similar, like overall more severe, and was that driving some of these kind of considerations and just some things that you noticed or looked at in terms of severity and patterns related to it?
Absolutely. So it turns out we actually had fewer people in the CDR2 group for all variants. The majority of patients for the non-fluent coming from CDR 0.5 and 1, as well as for the logopenic and semantic groups. So I would actually say that the representation of CDR2 is probably the weakest in these analyses. Part of that also comes from is that a constraint for the speech samples was they had to be at least 1 minute long. So just to really account for variability, what people have shown before with type token ratio analyses is that if you only have maybe 3 or 4 sentences, you aren't able to consistently recreate the result. So I wanted to have as much information as possible, which of course with the non-fluent group is really difficult starting at CDR 1, 2, just based on some of the comorbid deficits they may experience with motor.
Yeah, that's super difficult. I know the interaction with severity is a tough one to look at because if you have those type of restraints, it's hard to get people who are ranking in CDR2 or similar. Cool. I'll let someone else ask a question before I ask more of my other ones.
I was just wondering if you could explain the meaningfulness again. I wasn't sure then how you were able to compare healthy controls to meaningfulness. But maybe I wasn't really understanding the measure.
Totally. So task-specific meaningfulness was based off of the healthy control sample, where we took all of the words that the healthy controls used and looked at which were task-specific or appropriate to describe the picture. And we used that to create a corpus to then compare overall task specificity in someone's output. And so for the healthy control data, we basically looked at who used those two words as well, and then ran all of them through the corpus as well. So it was kind of this double iteration of first seeing, okay, what do all these people produce? And then the second step being, how do we compare it then to what we defined as being the typical way of describing something? So of course, the healthy control data is a little bit difficult to interpret, but I don't think that it's difficult to interpret them as a baseline based on this method to then look at variation within the PPA subtypes. I'm happy to explain any more about it too. That was just the overview of the utility.
That makes sense now.
Okay, great. And so we also only looked at nouns, verbs, and pronouns within this because while some people are still producing adverbs and adjectives, the healthy controls really didn't. And so I felt like that it would be falsely inflating if someone used one adjective and that added to another score. It really is about the words that carry the most meaning to describe this task here.
Any other questions? I definitely can ask some more, but I'll wait.
Well, first of all, thank you so much for that great presentation. I was wondering if you could share a little bit more about how you decided upon meaningfulness and TTR for your outcome measures, whether it was reliability or feasibility for this population.
Yeah, absolutely. That's a great question. I think initially everything presented here today was motivated by the fact that I'm just so interested in what makes someone successful in communicating. So taking away barriers of even just language differences, of what someone's experience with language is, based on their ability to describe something grammatically or the length of phrase that they use. I felt like I was just so curious about the patients that we did see that for some of them qualitatively were so easy to communicate with, but then you transcribe what they wrote and you think, wait, they're missing all of these aspects that we're told we need every day for language. And so that was the first motivation, to look at meaningfulness. And the second was to look at appropriateness of the meaningfulness of the message too. And that's driven by the fact that there are a few participants in our clinic that initially were diagnosed with logopenic PPA that developed into a Wernicke's-like presentation where they're so fluent when you look at just objective measures of fluency, and they produce so much language, but what they say has no relevance to what we're asking them. And so these two levels of meaningfulness were interesting to me to examine, just to see how well is someone able to be functional in a constrained context. Looking at variability, I did want to use something that has been established in the literature already to really use a standardized type of measure to then look at this aspect of lexical diversity, because I do also think it's really interesting to examine how much variability does someone have to have, how many unique pieces of information does someone need to offer to be successful in their communication. So that's where that was coming from too, just because Victoria, who's here, knows this, that there was one patient I spoke to who used maybe 10 different words overall, and I had the best conversations with her, and we had so much fun and just communicating and seeing how she was able to use them really well in different contexts, whereas there were some people who had much more access to a greater set of vocabulary who weren't able to use these words in a functional way. Of course, in this task, we are conflating variability with success, but I wanted to see what that relationship really was. Like, do you need to have greater variability to be more successful in your word class output? Great question.
We have another one.
I have a question. Can you hear me?
Yes.
Hi, this is Ayana Webb. And I was wondering how much of in terms of when you talk about the impaired patients, or the patients with aphasia, having more flexibility, possibly, if you can use that word, using verbs, for example, would you ascribe, sorry, that's my son in the background screaming, some remote learning, pardon me. Would you ascribe some parts of that to some compensatory strategies or methods?
That's a great point. So one thing I didn't control for is any type of additional therapy someone may have received in order, for example, to apply compensatory strategies. Most of our patients that come in clinic do receive up to 5 sessions of compensatory strategy work, but it definitely wasn't evaluated in a systematic way within the study to see who was able to apply them, for example, or to use them consistently. But that's a really great point, because if someone, for example, like the case of the woman who was able to communicate really well with 10 words in her arsenal, it's really not, it's really unlikely that she wasn't applying compensatory strategies in a fantastic way to be able to communicate at that level.
Yeah, that was my question too, so I'm glad
Thank you.
I asked that. I was also thinking, like, in terms of, we see this a lot with tangential descriptions too, so whether or not to count a tangential into what we would then score quantitatively has always been really hard. So I wonder if you compared samples where tangential information or other compensatory strategies, or even, I don't know, functional language, if you removed that from samples and examined it, especially in like the semantic variant, do you think you would see a different pattern if you removed that kind of information from their samples?
I mean, especially for the semantics, I think we would see a huge difference in the proportion of pronouns to all output if we remove the tangential information. For a lot of them, especially starting at CDR1, I feel like we wouldn't even be able to include them in the data sample based on the amount of tangential information provided. So we really had this incredible realization, just the amount of information that we see as meaningful because we understand it being produced, but so not relevant to the specific task as well. So I think that would be a really good comparison for this data as well, to look at the difference between meaningfulness versus task specificity and present that data.
Any other questions?
I'm also really happy to talk offline or with anyone about this apart from this conversation too. There are a lot of still ongoing analyses related to this. And I'm excited to talk through methods or, any feedback about this process as well.
Are you, I don't know if this is the case, contributing some of this data eventually to something like Dementia Bank? Are you guys planning to kind of contribute that open source?
Yeah, so at least part of it, some of the participants were recruited through an older IRB where unfortunately that wasn't accounted for, that we would share the actual transcripts, because especially for the semantic group, a lot of personal information is being communicated that could be identifying, but definitely for the ones collected after 2019. Especially because that would allow us to get those bigger group samples.
Yeah, for sure. Any other questions?
I have a question. First of all, I really enjoyed your talk, and I'm wondering from a kind of methodological standpoint, as you're recruiting participants, what is your procedure for classifying the type of PPA that they have? Given, as you mentioned, like and as we saw, there's great variability in kind of presentation sometimes, even within category. So what are your steps for for kind of ensuring agreement amongst the team?
Excellent question. So what I will say also, all the participants whose data was analyzed for this study, they were the ones where we said this classification feels as solid as it can get to, because we definitely do have these cases that some describe as mixed bags all the time. So the typical procedure in clinic is that we conduct a quite extensive language battery. We have about 15 assessments that we go through with them that examine and probe all of these different aspects of language, from articulation, syntax, auditory comprehension, single word comprehension, reading, writing, and all the subtests within each, verbal fluency, repetition. But what we also do is extensive caregiver interviews, as well as patient interviews. And if we have any other previous medical provider information, we also examine that. Because it's really common for a patient to say, oh no, I don't have a problem with that. And you start testing, or you talk to, not to stereotype, but often talking to the wife, if it's a male patient, you see, oh wait, there's a difference in history. There is something that, you know, the patient might not even be aware of to speak about. So we have all of those different pieces of information, and then we go through the progressive aphasia severity scale that was introduced by Brad in 2011. And that has all these different domains of language. And then we use the combination of caregiver report, patient interview, neurologist clinician interpretation and evaluation, and then of course the standardized assessments that we use to then come up with scores from 0 to 3 for each. And so then those scores are then reviewed by a licensed speech language pathologist to go through to really see, okay, is something objective? Is it qualitative? Do we feel like they're really fluent? And then someone looks at the transcription of what they said and says, they're very good at filling in information, but maybe they're not actually communicating something in between. So that is our procedure. It doesn't come out without errors at times too, and we have, especially in the mixed cases where we have someone who has impaired syntax, impaired single word comprehension, but seems to be retrieving a lot of words upon picture recognition. You know, that happens, and then those people are categorized differently, and we have extensive note taking for them, and we project a potential diagnosis or combination, but those are the cases that are flagged.
Great, no, thank you very much. And I think we all are kind of struggling with those challenges. We had a great conversation recently with one of our neurology colleagues who was looking at the PET scan and thinking, okay, the patient must have this. And one of our speech pathologists had evaluated the patient, said, I'm seeing the semantic variant. He was leaning more towards logopenic just based on the imaging, and having to reconcile that. It was a great conversation, and we could see where each party was coming from. But we have those challenges. I feel like they're more messy than not in many cases, but I like your approach for handling that.
Yeah, we definitely have part of our clinical rounds, we have only behavioral discussions for the first 45 minutes. Yeah. And then we move on to the imaging, and we always have to guess beforehand. Everyone has to guess. What do you think you'll see? And it's always, I would say 50% of the time we're slightly surprised also. So that is definitely a place for continued work to really figure out, are there signature maps, and do those signatures reveal that there actually are more subdivisions within the variants?
Great, thank you.
Thank you.
Yeah, thank you. Thank you very much for this presentation. This is really great. I also wonder, in terms of down the road, like, can we account for how things may be, and I guess it's along the wave of compensatory strategies, but if there's a neuroplastic element to this, like, is there like a moving goalpost to all of this? So that's why it's so good to hear this presentation, because I feel like it can give us a place to start. So thank you again.
Thank you. My personal dream for later, after I defend my thesis too, would be to look at TMS to see the immediate effects of applying stimulation versus not on someone's ability to communicate a specific message. beginning with healthy controls and then examining how that could be contextualized within a treatment as well for individuals. So I think my struggle too a little bit is determining the emphasis of the treatment as well for this kind of a measure. And I think right now it would be truly word-based, where you focus on the words produced with the nouns and verbs. But I think that would be the most immediate measure of change in this case. But I think that is one of the things that we're all really motivated towards, especially in the progressive versions of aphasia. How can we best serve someone to improve their ability to functionally communicate as long as they can? And so looking at these types of methods will be really important to then apply how we can improve discourse.
Ooh, didn't want to unmute there. Sorry about that. That was fantastic. Also I guess, big congratulations for almost being at the point where you're ready to defend your dissertation, which is very exciting. So best of luck with that. And as Jen said, if you want to get in touch with her, her contact information is on the member directory in Focus Aphasia. She's also easily Googleable. But we would love to facilitate any further conversations about this offline. And she has a lot more data to share, I know. So there's also probably more talks that I will be soliciting from her in the future. She's been pegged. But I think I speak for everyone when I say that was a really fantastic talk. I learned a lot. I think, as Ayana said, this is a moving target in terms of what we know about PPA and what can help us to be better at predicting outcomes, right? Improving prognosis, even understanding at a neural level what's going on. So I just wanted to thank you for being here today and taking this time with us.
Thank you so much. And I apologize for speeding through the first few slides, but we got there.
All right. Thanks all for coming. This will be on our YouTube channel soon if you want to share it with friends.